Well, for this month's Editor's Choice, we're very pleased to have Professor John Hodges talking about his study on diagnostic criteria for corticobasal syndrome. So good evening, John.
Oh, hello, Matthew.
Perhaps you could fill us in a little bit about the background in terms of coming up with this study and what you were really trying to achieve through it.
I mean, one of the problems we have in neurology is that many of our diagnoses are clinical syndromic diagnoses, and we don't have access to pathological confirmation of the diagnosis. And people apply criteria, or supposedly apply criteria for different disorders, whether it's Parkinson's disease, Alzheimer's, corticobasal syndrome, and trot these out. But on the whole, there's rather little attempt to validate and compare. So I've been interested in corticobasal syndrome, as we call it now, for a number of years, particularly as we've begun to realize how variable the pathology is when people die, and that the patterns and profile of clinical presentations can be quite different. So we decided to have a look at all the patients who'd presented to a busy clinic in Cambridge, and we were fortunate enough to have been able to follow up nearly all of these patients. So what we wanted to do was really look at the clinical criteria that have been used by three major groups working in the area and simply compare them to begin with, and then to see how applicable they were to this group of patients. We looked at the criteria that have been used by the Toronto group, by the Mayo group, and that we ourselves had used in Cambridge. And we took all of the patients, we looked at how many would fulfill the criteria when they first presented, how many would fulfill the criteria a few years later, and how common are some of the signs that are regarded as very classic of corticobasal syndrome, like alien limb phenomena. Then we saw whether some modifications to the criteria would help, particularly in the earlier stages. And the real point of this is to have some standardization of criteria that one can compare systematically, and then to look at things like rates of different pathology, and perhaps to use these criteria as drug studies start to become available.
So from your sort of clinical perspective, what do you see as the key sort of features that would make you suspect the diagnosis in the first instance? Yes.
Well, I think from our perspective, corticobasal syndrome started as a very movement disorder defined condition with Parkinsonism and asymmetric apraxia, and emphasized some of the features like alien hand, which are actually pretty unusual even in the advanced stages. And one of the key findings from this study is the prominence of cognitive symptoms early on, particularly language difficulties, word-finding problems, speech difficulty, and writing and spelling problems. So I think until now, people have sort of tended to be thinking, oh, well, it must be something else if they've got these cognitive features. And in a high proportion of patients, the cognitive and language features dominate. That's what the patients come along to the clinic complaining of, and the apraxia and Parkinsonism are picked up on examination. Apraxia doesn't have to be the presenting symptom. That's one of the important take-home messages.
And in terms of that, then you mentioned writing difficulties, and you have mentioned limb apraxia. Are you saying the writing difficulties are related to the apraxia, or is that related more to the cognitive?
Well, that's very interesting, and that goes beyond this paper a bit. from my own experience over the years seeing these patients, they complain of difficulty with writing, but the difficulty isn't just manipulating the pen and forming the letters. They've actually got a spelling disorder as well. And the areas of the brain that are related to hand manipulation and the praxic aspects of writing and the more cognitive aspects of writing and spelling are fairly closely related. And so I think that's one of the things that more general and movement disorder neurologists may not think of.
Now, having established these diagnostic criteria, what are your plans in terms of longitudinal studies, and then what do you think would be a good approach in terms of management?
Yeah, well, it's clear that the pathology underlying corticobasal syndrome, which is why the terminology has shifted from corticobasal degeneration to CBS, because the original papers in the sort of 60s and 70s, which came out of movement disorder clinics, talked about it as having a very specific pathology, but it's become clear that quite a high percentage have Alzheimer's disease, some have PSP pathology, some have the classic sort of tau-positive corticobasal degeneration. So one of the important things I think now is to see whether there are nuances to these criteria that separate out the Alzheimer's from the tau longitudinally.
So based on your findings, do you think that we should give equal weight to the movement disorder criteria and the cognitive symptoms, or do you really think that maybe the cognitive symptoms are predominant?
What we proposed in the paper, we proposed mandatory criteria, which were basically that it's a gradually progressive disorder. And then we had major criteria, which were basically akinetic rigid syndrome, limb apraxia, and cognitive dysfunction. And that could be speech and language or executive function. And to make a diagnosis, you should have two of those three features. An interesting issue is whether perhaps the Alzheimer patients all have the cognitive features to begin with. Maybe some of the non-Alzheimer cases have the other two, but not the cognitive right from the beginning. So we've sort of broadened the criteria. I think, there's a general point about neurodegenerative diseases and the situation we're in at the moment. We very much come from a medical perspective that we can diagnose in life based on a cluster of symptoms and signs, a pathological entity, and then direct therapy based on that pathological entity. There's a problem, in neurodegenerative diseases that all the syndromes that we diagnose, when we say somebody has Parkinson's disease or even motor neuron disease, and definitely, FTD and corticobasal, there are a range of pathologies now that we know can cause each of those syndromes, a range of pathologies and a wide range of different gene defects. And so one of the great challenges is sort of going between the clinical syndrome, the pathology, and the genetics. We've got to have greater clarity about the definitions of the clinical syndromes. So I've been very much involved over the last few years in improving diagnostic criteria for the different forms of frontotemporal dementia, the behavioral variant, the forms of progressive aphasia, semantic dementia. And so this work on corticobasal syndrome really fits into that broader picture of getting better criteria so we all know what we're talking about, then trying to relate the pathology to clinical criteria and getting better in vivo measures biomarkers, if you like, of underlying pathology in the brain.
I think it's really a classic disease in terms of its evolution. As you said, like when I came across it first, it was very much in the movement disorder sphere.
Yeah.
But the cognitive input was not really properly appreciated.
Yeah.
And that is certainly something that has come to the fore over recent years, particularly through your work. And in a way, would you claim corticobasal degeneration more as in the realms of frontotemporal dementia as opposed to more a classic sort of movement disorder, acromegaly rigid syndrome?
Another very important aspect is the impact of the disease on the patient and the families. The cognitive dysfunction, it's bad enough having difficulty walking and a tendency to falls and difficulty with hand control, but these patients also have, almost universally, by the time the disease has progressed a bit, major cognitive problems, which overlap very considerably with the syndromes that you see in frontotemporal dementia. So it's really part of the broader rubric of frontotemporal dementia with some added motor disorder, I would see it as. And I would argue that the patients are best sort of managed in a way in a cognitively oriented setting with nurses and staff that understand the cognitive aspects.
Well, John, it's really a fascinating study, and it's also been highlighted with an editorial commentary from Rabinovici and Miller, discussing again the overlap between movement disorders and cognitive dysfunction in this neurological disorder. So thanks for giving us your insights.
Great pleasure to do so.